they've been in a variety of different tumors. We've moved ahead and a number with adding one other anti-cancer agent. And more recently, we've moved further ahead by adding a number of them. This is a summary of those 12 studies that have been performed from a variety of institutions, including MD Anderson, some in Italy, also here in Taiwan, Memorial Sloan Kettering, etc., in a variety of different tumors. This is just a summary of the tumor responses that have been observed. And I think the take-home point here is that from some of the monotherapy studies that we have seen some responses, but then as has been commented on by multiple discussants this morning, that when you add another agent to ADI, that the number of responses increases, and it's even greater when two agents are added to ADI, suggesting that the future of ADI appears to be in combination therapy and not in monotherapy. Well, we've also learned that overall survival correlates with the ASS1 level in HCC. This is from the study that was performed here in Taiwan. And the retrospective analysis that was available from 44 patients showed that 75 were ASS deficient, whereas 25% were ASS positive. And those who were deficient responded well to ADI with a significantly longer improvement in survival with that monotherapy. Again, similar results were observed with monotherapy in melanoma, a study from the University of Miami. And retrospective analysis again was performed. Of those patients that were ASS deficient, they had a median survival of 13.5 months, and they had a significant number of partial responses and also stable disease. Now, in contrast, for those 10 patients that were ASS positive, their median overall survival was clearly less, and there was little in the way of responses. Thus, again, in another tumor showing that ASS is very important for ADI in terms of ADI monotherapy. Peter Schlozerak has already talked about in his monotherapy trial in mesothelioma of another example where progression-free survival correlates with the ASS level, and that the greater the degree of ASS loss, the more likely patients are to respond to ADI monotherapy. Again, continued proof of principle by 3 different cancer types from 3 different investigator groups. Also, we know that overall survival correlates with the degree of arginine depletion. Excuse me. This is again from the Taiwan phase 2 study. And the longer that arginine can be depleted, the longer there is improvement and survival. This is from the more recent phase 3 study that Gassan had presented earlier today, pointing out again that those that have arginine depletion for greater than 7 weeks do much better than those who have arginine depletion for a shorter period of time. So there's 2 things that we've learned here is that at least for monotherapy, that ASS deficiency seems to be required for ADI to work. And second of all, that arginine depletion does correlate with survival. So what can we do to try to enhance the degree of arginine depletion and thus hopefully improve the overall survival? This is an example of how combination therapy can improve the number of responses but also prolong survival. And this again was some of the data that was presented earlier today from Eileen, who were using pancreatic cancer here, pointing out that with the combination therapy, that arginine stays depleted for a longer period of time. And the antibody titer does not go up as much as what has been seen with only the monotherapy. So that, again, that with the combination therapy, that the combination therapy not only has the benefit of the cytotoxic drugs attacking the tumor, but it also helps to help to prolong the arginine depletion, at least in part by decreasing the antibody titers. And again, that's known in other cancers that for a long period of time, cytotoxic agents like cyclophosphamide, for example, have been used to treat patients that have kidney cancers, for example, to try to decrease the antibody response. Here's another example, pointing out in more graphic detail from multiple studies that if one takes ADI and uses it either as monotherapy or in combination therapy, what happens to the degree of arginine depletion? So here we can see what happens with monotherapy, how the arginine levels go up more rapidly. And here's what we can see from multiple studies of either combination with one drug or with two drugs. There is a significantly prolonged arginine depletion, and we know that it leads to prolonged overall survival. And again, most of these combinations can significantly extend the duration of arginine circulation from not just 8 weeks, but to even greater than 16 weeks. The next area that I'd like to talk about that we heard this morning again was about the safety of ADI. This is some data that talks about the comparison in hepatocellular carcinoma with the standard first-line agent sorafenib, again, data presented by Hassan. And what this just simply points out is that ADI, again, as monotherapy, remains very well tolerated. And again, this would be expected because normal cells have arginosuccinate synthetase, and thus would be expected to make arginine and would not be harmed by arginine depletion. Again, there is some injection site reaction, which one will see with ADI because it is given by intramuscular route of administration in contrast to sorafenib. But again, as talked about by both Drs. Abu Alpha and Dr. O'Reilly, and also by Dr. Schlozerac, that the data with the injection site reaction tends to be really quite mild. This is also again data from the phase 3 study of hepatocellular carcinoma where there's a placebo control group. And Dr. Abu Alpha went over this in detail earlier today, pointing out that what you see with placebo is what you see with ADI. So again, a summary of what we have so far is that ADI is administered intramuscularly. Patients typically receive the treatment once a week as outpatients. They're observed for an hour and then released. They do not require extensive hospital stay. ADI has been tested clinically in 19 clinical studies, including those that have been, dozen that have been completed in a variety of patients with end-stage cancer types. Over 1,200 patients worldwide have been treated. We have patients that actually have been on treatment for over 4 years. It's demonstrated apparent anti-tumor activity with an excellent safety profile, and only approximately 3% of patients have dropped out of studies due to adverse reactions. They're typically immunologic events such as rash or injection site reaction. It has been combined with other chemotherapies and has resulted in prolonged arginine depletion, objective responses, and a very prolonged survival. Thus, in addition to these complete and partial responses, patient survival was extended without sacrificing quality of life. And again, you've heard about that again this morning from Drs. Abu Alpha, O'Reilly, and Schlozerac, that when ADI is combined with cytotoxic therapy, that one tends to see nothing more than the cytotoxic therapy in terms of adverse events, except for the injection reactions consistent with the ADI route of administration. So, Again, back to what we heard about this morning, Dr. Alpha mentioned that the phase 3 monotherapy study did not meet its primary endpoint. However, we did learn the following lessons. Number one, sorafenib induces ASF expression. Our plan, conduct a first-line study with sorafenib as the control in ADI-PEG20 combined with FOLFOX in patients that are naive to therapy. Lesson 2, arginine depletion correlates with overall survival, and arginine needs to be depleted within 7 weeks in these HCC patients. Our plan, 1, use a higher dose of ADI, 36 milligrams instead of 18 milligrams as was used in the phase 3 trial. And 2, combine ADI-PEG20 with other drugs. Cytotoxic drugs suppress neutralizing antibody ADI-PEG and attack the tumor in a different way than ADI-PEG20. Again, just to reemphasize, from this, that all of these trials are attempts to learn. And as you heard from Dr. Alpha and also from Dr. O'Reilly, multiple other companies with multiple other drugs have failed in late-stage trials with their studies which they've moved forward. And not for a lack of preclinical data and not from a lack of phase 2 data. That this is one of the things that does happen in terms of clinical trial development. And the important thing is to be able to learn, is there something that we can move forward with, which is what we're trying to do here with ADI. Next, the combination therapy of ADI-PEG20 attacks the tumor through multiple mechanisms and can be more effective than ADI-PEG20 monotherapy. And we've heard exciting phase 1B results obtained in mesothelioma, non-small cell cancer, pancreatic cancer,